are going to go through the presentation of Rachel Yantzi about communication, empathy, and trust, the life experience of caregiver staff and relationships while providing palliative care and end-of-life care to children in Bangladesh. So she's a pediatric critical nurse from Canada with experience in different settings in MSF. She has a master's degree in community health, nursing, and public health, and a bachelor's degree in nursing. And she's doing a PhD in her research methodology. So we're going to her. Rachel?
All right, welcome everyone. My name is Rachel Yantzi. I'm former nursing activities manager with MSF, and today I'll be presenting results of the study, Communication, Empathy, and Trust, Lived Experiences of Caregiver-Staff Relationships while Providing Palliative and End-of-Life Care to Children in Cox's Bazar, Bangladesh. Our study took place in the context of the Rohingya refugee crisis, where nearly 900,000 Rohingya refugees have fled violence in Myanmar and now live in overcrowded camps in Cox's Bazar district. As part of the response, MSF runs the Goilamara Mother-Child Hospital, which offers the highest level of care for neonatology and pediatrics available in the camps. The aims of our study were to document and describe the lived experience of providing palliative and end-of-life care in Goilamara Hospital in order to inform program implementation in this and other MSF contexts, as well as to understand the ethical implications on staff of integrating palliative and end-of-life care into holistic care. Our study took place during the early stages of our palliative care program implementation. And today I'll be focusing on findings related specifically to the staff experience of their relationship with parents and caregivers. This focused ethnography took place between April and August 2021. We conducted a total of 22 individual interviews with a variety of staff who provide patient care. The majority of our interviews were with locally hired staff, and we conducted 5 interviews with international staff. We also did 5 focus group discussions, and all the interviews and focus group discussions were conducted in English, Bangla, or Rohingya. They were audio recorded, transcribed, and translated to English as needed. We also conducted participant observation of activities and staff interactions with patients and families, and collected protocols and other documents relevant to the topic. Narrative summaries were written of each transcript, and all data were coded in vivo data analysis software. Ethics approval for this study was obtained from MSF, as well as the Bangladesh University of Health Sciences Ethics Review Board. I'll begin by presenting a vision of the staff's vision of their relationship with parents and caregivers. When staff were able to achieve this vision, they described feeling fulfilled by their work providing end-of-life care. First of all, staff felt that gaining the trust of parents was critical, and all of the concepts to the left of the diagram were seen as foundational to that trust. First of all, it was important for parents to believe that the staff had done everything to save their child's life and had done their best on behalf of the child. The Bangla concept of Maya was also very important to staff, which loosely translates as tenderness and affection for the child. Based on a sense of shared humanity, staff imagined themselves in the parent situation and tried to treat caregivers as they would treat their own family. One nurse in a focus group discussion said, "I have to put myself in their place. As a mother, as a father, we have to understand that place. Then they will trust us." Staff emphasized also the importance of honest and clear communication so that parents believed and understood what they were explaining to them, as well as psychosocial support and accompaniment of families. When all of these aspects were fulfilled, staff reported feeling appreciated by families and valued for their work caring for children at end of life. One mental health counselor quoted a parent who said, "I received a lot of support and felt courageous by staying among you, and I have found an environment that has reduced my suffering because of the trust I have in you." There were 4 main ways that this relationship with families and caregivers sometimes broke down. Often aspects of the context contributed to these relationship breakdowns. The first was when staff described fearing that they were being seen as a mechanical person. The staff really valued the importance of empathy, but sometimes they struggled to balance the feeling the parents' suffering while protecting their own emotional well-being. They worried that they sometimes came across as unempathetic or that they were becoming hardened by the amount of death they experienced at the hospital. One Bangladeshi doctor said, "When we are breaking that news, it's really difficult for us because the patient party doesn't realize that we empathize. Sometimes, yes, I'm feeling sad, but it's not in my mouth because I have to see more patients." Staff also repeatedly described communication challenges and their frustrations when we are saying one thing and they understand something else. The absence of health promotion, staff, and translators on night shifts, as well as the challenges of explaining a palliative approach and cultural and language differences led to a lot of miscommunication and frustration. One of the most hurtful things for staff was when parents blamed them for the death of a child, which often happened after an unsuccessful CPR attempt. And finally, even while staff found it very hurtful to feel blamed by families, staff also sometimes experienced blame directed at parents. They felt significant distress when they felt that parents' choices were contributing to a child's death. One Bangladeshi doctor described his feelings about parents who delayed seeking care. He said, "Initially, truly said, I felt a little bit frustrated. I was asking myself why they are doing this all the time. We are trying for better management for the patients, but after my experiences, it's not actually their fault. They have been deprived since the very beginning." It seems that an understanding and empathy for Rohingya oppression and experiences of healthcare trauma seem to mitigate their distress. In conclusion, it was clear that positive relationships with caregivers may alleviate an important source of moral distress for MSF staff involved in pediatric palliative care. Importantly, access to trained medical and cultural translators 24 hours a day, 7 days a week was crucial to facilitating positive relationships with caregivers. And either before or very early in a palliative care program implementation, training and support is needed to facilitate safe and open spaces for staff to share their concerns, strategies to balance empathy with self-care, skills related to communication, family-centered care, and grief resilience, and training around the impacts of health trauma and healthcare exclusion for the community served by the hospital. I just want to thank the staff at Goilamara, the Operational Research Committee, and all of my co-investigators for their support with this project. Thank you.
Hello. So thanks, Rachel. That was really inspiring. I have a question for you. Did you find that using translators created a distance between the staff and the patients at such a critical and sensitive time? And if so, how did you get around that?
Yeah, I think this is one of the really challenging things at all levels within the hospital, was the way that almost all communication was happening through translators. And I think trying to find the words to express some of the concepts involved in palliative care were quite challenging. So yeah, definitely, I think that was a really challenging aspect. Even when you have access to translators, it creates a barrier.
Thanks, Rachel. I think we have to move on, and I really appreciate your presentation. This is really a topic that we would not have been able to have even some years ago. So you're really at the front line of elements that have to be done better in humanitarian settings. Thanks a lot, Rachel.